Greetings to ZTV viewers. I am Dr. Sudhakar Jonnalagada, President, American Association of Physicians of Indian Origin, API. Last month, first episode, you all learned a lot about lung cancer. Today, we're going to talk about heart diseases in India. I'm sure you all want to know why they are high in Indians. We have very exciting faculty today. Let me introduce our moderator today, Dr. Srini Gangasani, board certified cardiologist from Atlanta. He is a past vice chair of board of trustees of API and convention chair in Atlanta and chair of Global Healthcare Summit, Hyderabad. Please welcome Dr. Gangasani. Dr. Gangasani, welcome to API Outreach Program.
Welcome to the API Health Awareness Program regarding heart health for the Desi heart. Thank you, Sudhakar, for that wonderful introduction. Heart attacks in Indian subcontinent is more prevalent, occurs at 10 to 15 years earlier than other ethnic groups. For example, Indian subcontinent has about 2 billion people, which constitutes about 25% of the world population. But Indian subcontinent accounts for 60% of the total heart disease in the world. Not only that, when the sudden death happens, it occurs more frequently. In the United States, when heart disease occurs, about 5% of the people have heart disease before 50. If you take into Indian subcontinent, this risk is about 30% before the age of 50. So given the aggressive, severe, diffuse disease, we need to protect our Desi heart as much as possible. Let's know how to make this Desi heart healthy from the panelists. Our first panelist is Dr. Sujit Poonam, who is a board-certified interventional cardiologist from Stockton, California. He is a regional director of API Pacific Zone. He's also a global champion for prevention of sudden cardiac death. Welcome, Dr. Poonam, for this program.
Thank you, Dr. Gangasani, for having me. It's a very important topic. As you know, it's the number one killer. Heart disease is the number one killer among the Indian population. Every organ in the body, heart also needs blood supply to survive. This blood supply is provided by what we call as coronary arteries, and they sit on top of the heart. Due to some conditions, which we call as risk factors, these arteries develop fatty deposits inside the lumen called as atherosclerotic plaque. In common terms, we call them as plaques. So when the plaque buildup happens gradually and reaches to the point of about 70% or more in general, the mismatch between the oxygen demand and the supply contributes to the heart manifesting symptoms to warn us, and usually it takes the form of a chest pain. This is called angina. Once in a while, the plaque ruptures abruptly, and all of a sudden the blood clots in that area, shutting off the circulation, leading to the death of the heart cell. That is called a heart attack.
Great explanation. Thank you. Can you explain, I think we talked about the risk factors a little bit when you're talking about it. Can you explain what are all the different risk factors to have a heart attack?
And those are being of higher age, being of male sex, smoking history, hypertension, diabetes, hereditary factors, high cholesterol, type A personality, being overweight, etc. And these are the risk factors that we call, and then they contribute to the plaque formation and eventually heart attacks. Some, as you see, are modifiable and some are non-modifiable.
So what are the tests or the different kind of things we can see to identify and predict these people to prevent a heart attack?
We classify it as mild, moderate, and high risk. For mild risk, we usually recommend lifestyle changes. For moderate risk, we could consider doing a CT scan to look for coronary calcium scores to get more information about the plaque formation and the bulk of it. This works on the basis of a premise that calcium gets deposited on the plaque as time goes by, and CT scan can pick up the calcium since it is radio opaque. For high-risk patients, we usually recommend cardiac stress testing to challenge and see if the plaque causing the chest pain should be treated with medications only, like aspirin, statin, etc., or they would need stents or bypass surgery. Then we can do an EKG, an electrocardiogram, to look for any rhythm disturbance or other changes that we can see if there is any blood supply problem. We can also do an echocardiogram, which is basically an ultrasound of the heart, to look for the squeeze function of the heart, thickness of the heart, valve function, etc. If at any point someone has symptoms, which we would run some of these tests based on the type of the symptoms without even calculating the risk score.
So when people get these symptoms, a lot of times, every day in and day out, people get some chest pain, shortness of breath. Can you explain our viewers when is the good time to go to the hospital or call 911 or EMS so that they can taken care of? Just make sure that they're not having a heart attack or really something non-cardiac.
Well, if the plaque built up gradually grows, which we called as angina, this can be assessed in the physician's office setting, and tests can be run and risk stratification can be done. But if the symptoms happen abruptly, you should get it checked immediately without delay. And at that time, you should call the EMS system, which is 911 in the United States. Symptoms of the heart attack include chest pain, chest pressure, some people call it heaviness, shortness of breath, sweating, palpitations, etc. This chest pain sometimes can radiate to the neck, to the arms. Sometimes more commonly in women and in diabetics, especially, symptoms can be atypical and they could be manifesting now nausea, fatigue, belching, etc. Some people confuse heart attack with cardiac arrest. They're different entities. Cardiac arrest is an electrical abnormality of the heart where a person collapses suddenly when the heart goes into a virtual standstill. Heart attack can cause cardiac arrest, but usually not the other way around. Needless to say, you have to call 911 if someone with above risk factors collapse without a good reason.
I think given that there are so many different symptoms people can get, I think if they're in doubt, I think it's better to be checked out rather than not. Thank you for that excellent discussion. Thank you, Dr. Poonam. Our next panelist is Dr. Sharma, who is a well-known cardiologist from New York. He is Director of Clinical Cardiology, Dean of International Clinical Affiliations, and President of Mount Sinai Heart Network. Welcome, Dr. Sharma. Thank you for taking time to answer some questions for our viewers. Dr. Sharma, so we know heart disease is very prevalent in Indian community. So what are the different ways of managing patients with a heart disease, either patient come in with angina or when they come in with heart attacks?
Yeah, Dr. Gangasani, thank you very much for giving this opportunity on very vital topic. And the sobering statistics which you said, they're absolutely correct. So that the heart disease in Indians, whether they are living in India or they are living in US or out of India anywhere, Europe or the UK and anywhere, they have a disease coming early stage, more extensive, more diffuse, and has small arteries. So basically, the question comes that what are the different ways to manage these patients? So there are two group of patients when they present with a heart disease. One we call stable angina, means they have a chest pain or have a positive stress test. Or secondly, they're having a severe chest pain causing heart attack, whether it's a ST segment elevation, which we call classical MI, or non-ST segment elevation, which is more of acute coronary syndrome and unstable angina group. So key is the treatment, at least for one disease, has been well established. That somebody who present with acute chest pain and electrocardiogram shows ST elevation, that patient belongs to the cath lab. So not only in United States, 96+% of these patients go to the cath lab. Even in India, there is a rapid movement taking place in various countries that even from the small village, the patient with STEMI are rapidly transported to a tertiary center to get the stent angiogram and angioplasty and to get the stent procedure done. So STEMI patients are clear cut. The non-STEMI patients, that patient do have severe angina, but they are not having the S segment elevation, means there is so much urgency to take care of those. So those are initially managed on medical therapy, and within 1 or 2 days, the majority of them, they go to the cath lab because of persistent symptoms. If they go to the cath lab, then we decide whether a patient just continue medication, or we need to open up with the stents, or patient if have extensive disease, they go for bypass surgery. The third group, which is the most controversial, which has come, is the patient with a stable ischemic heart disease, which we call SIHD. This is the field which is really evolving by various trials, and it turns out to be that in majority of the cases with ischemic heart disease, stable ischemic heart disease, medications do as good a job as more invasive stenting or bypass surgery. But by and large, stable ischemic heart disease patients do quite well on medical therapy. Recent data after the old being Courage trial, recent ischemia trial showed us that it's completely safe. The patients, even with a positive stress test, having angina, they can be well managed on medical therapy. If they fail medical therapy, then of course you can cross over for an angiography and then subsequent revascularization.
Thank you. That was an excellent outline of all the treatment options for heart disease options. So, are there any major differences in our anatomy, what the arteries look like? I know you said there is a little bit of a smaller arteries, and we see all the time Indian arteries being a little smaller compared with the Caucasian arteries. So, when you're taking somebody of Indian origin, taking to the cath lab, or when you're sending to the bypass, what are the major differences in the Indian patients versus other ethnic groups?
So very important point. So key is what has been reported, that even when patient present with STEMI, ST segment elevation, if it's a non-Indian, the chances that there is only one artery blocked is almost 70%. But even during STEMI situation, if there is an Indian from subcontinent, whether India or here, the chances that there is more than one artery blocked is 80-90%. So they usually have multiple arteries blocked. Secondly, has been shown that genetically our arteries are small. They're more diffusely diseased. Means what diffuse means? There are multiple blockages. What is a small artery means? Small means the artery less than 2.5 millimeter, your major arteries. Most of the atherosclerosis blockage is from cholesterol deposit. But somehow Indians, whether because of our diet, right from the beginning, we are forced to drink a lot of milk, yogurt. So whether it's give rise to more calcium deposit in the coronary arteries. So calcific arteries are also very common in our Indian patients.
The next question is, we see a number of times people who had a stress test or even a catheterization, their arteries are normal or mild disease, 20%, 30%. And these people go home and they say, "Yeah, my arteries are fine and I can do whatever I want." And suddenly we see people coming back with either a heart attack or a sudden death. Could you explain our viewers why this happens and what we can do to avoid these kind of complications?
Cases which you mentioned, that I know many of them, negative stress test, but did come down with a heart attack or died for some reason in next few months after a quote unquote negative stress test. Although negative stress test could be sometimes, we call, if there is a blockage in all three arteries of the heart, we call balanced ischemia, that there is a decreased blood flow in every segment, and that may appear that is stress test was negative. That CAT scan, CT angiography with calcium scoring should be the main screening test. And I can tell you that once you're CT negative, chances you have a heart disease is nil. When CT is positive, it shows blockage. It may be that sometime overestimate because of calcium and various factors. But therefore, CT angiography has become the routine standard screening test, at least for me. It's not uncommon. You'll get a calcium score of 200 or 500, and there's not much blockage. So that's good. So now you have caught this patient in a very early stage. So aggressive treatment by reducing their LDL cholesterol to less than 70, bringing their HDL up, and of course exercise routine, losing weight, and various other risk factor modification may regress the disease.
Thank you, Dr. Sharma, for that excellent review of whole management of cardiology and cardiovascular prevention. Our next panelist is Dr. Alka Kanaya, who is a professor of medicine at University of California, San Francisco. She is a practicing internist. She has led the Masala study, which is mediators of atherosclerosis in South Asians living in America. This is the biggest cohort study in South Asians to look at the risk factors in this cohort. Dr. Kanaya, welcome to the program. Find out about what are the main findings of this Masala study.
Sure. So we've been following 1,150 or more South Asians in this study for almost 10 years now. And we set up the study to be parallel to an ongoing study in the US called the MESA study, Multi-Ethnic Study of Atherosclerosis, which has whites, African Americans, Latinos, and Chinese Americans, because we wanted to compare South Asians across these other four groups to see are there similarities and differences. And what we found is striking. South Asians in the study have much higher rates of diabetes, higher rates of high blood pressure, and also higher rates of atherosclerosis. And by that, I mean hardening of the arteries or calcium deposits in the arteries. And this is despite having a fairly low or normal body weight. But we also found that even if people have low normal body weight, they still have a lot of risk factors. And these are the risk factors Dr. Poonam was talking about. And what we found is that South Asians may be at higher risk of developing heart disease, as well as all of these other risk factors like diabetes and high blood pressure, because of our propensity to deposit fat in all of the wrong places. Possibly our way of conserving, energy, that these fat deposits are actually causing more harm than good.
What can our Indian community to do to prevent these heart attacks just because of all those risk factors?
Yes, I mean, this is the crux of our study, is really to look at what are the social factors, what are the behavioral factors, dietary factors, what can we do to modify the risk? And the good news is there's many things we can do. It's not inevitable that you're South Asian and you're going to have a heart attack. That is absolutely not true. There are so many things within our control. One is, knowing your risk factors. So getting a checkup done, knowing if you have high blood pressure, knowing if you have diabetes or pre-diabetes, knowing if your cholesterol is abnormal, and then using behavioral changes. So healthier diet, more exercise, stress reduction, other things to improve your overall quality of life and to prevent these things. But also, if you need to, be on proper preventive medications. So I am a big proponent of doing the calcium score in people who we don't think are already high risk.
I agree. I think I do a lot of calcium scores in my practice, especially somebody who has a family history of a lot of risk factors like diabetes, hypertension. Now, let's talk about a little bit about our Indian diet. We think our diet is reasonably okay, but what do you think about the influence of our various Indian diets on our health, especially cardiac?
Yeah, we've spent a lot of time and energy actually trying to do the best measurement of diet, because when we looked at these three dietary patterns, the people who were eating the Western diet, which was heavier in animal protein, And the people eating that traditional South Asian diet, which was vegetarian, they had the highest risk factors. They had higher blood pressure, higher weight and waist circumference, lower HDL cholesterol, more insulin resistance, so more likely to have diabetes. The people in that prudent diet, the fresh fruits and vegetables, had the lowest risk.
Great. I know we always people think vegetarianism is kind of protecting, but you have to do the right vegetarian food rather than any vegetarian food. Thank you, Dr. Kanaya.
My pleasure. And I want to let people know that please go to our masalastudy.org website. We're constantly updating it with health resources for South Asian communities around the world.
In conclusion, as our panelists alluded to, Indian subcontinent people have a higher risk of heart disease, which is more aggressive, occurs early, and 2 to 4 times more common than other ethnic groups. Early prevention with aggressive risk factor modification coupled with lifestyle changes with early diagnosis and management are very important, especially in groups where there is a family history of heart disease. If you look at the risk factor modification in the United States, by just controlling the high blood pressure, high cholesterol, and educating people about tobacco use, mortality has gone down by 70%. We can do the same thing in the Indian subcontinent by people taking care of themselves by aggressive risk factor modification, maybe some help from governmental initiatives with public health measures to increase awareness of risk factors for the heart disease. I would like to thank API President Dr. Sudhakar Jonalagada, Outreach Chair Vinod Sinha, and our excellent speakers and our sponsor 27th Investments for making this program possible. Stay safe, stay healthy. Thank you.